What have we got?
Dr. Rand, hope all is well. I am a 44-year-old male. I recently went into a TRT clinic in West Des Moines, Iowa. I have had insurance clients of mine that have been using TRT for some years, and it shows. I went into the T clinic last week to see what it was all about and to get my blood drawn. From that Thursday to Monday, I went hunting on YouTube for people's results, etc. Then I came across your channel and many others. My blood draws came back with a total test of 334 nanograms per deciliter, and the nurse practitioner, main person at the location, flew through the rest of the stuff. The only thing I caught was the total test. I should call back to see what the free test was at. Basically, she said your numbers look good besides the test level, and I'm a candidate for TRT. Then gave me the blanketed cell of HCG and AI and cypionate 1 time per week. My question is this. A guy on YouTube, Jake, was going off on how terrible AIs are for you. Kind of freaked me out to the point that I started to challenge the nurse practitioner. Red flag. She didn't know what I was talking about when I said AIs. She also said that anastrozole doesn't block the receptors. She said it only gets rid of the extra estrogen produced from the extra test. Okay. Not sure how the body discerns from some estrogen and not all. Well, it doesn't. If that's, okay, I'll keep reading. If I took the AI, can it hurt me? Saying that even a microdose can cause brain fog, which is a medical condition, not. Vascular issues, joint issues, bone density loss, and it stops the breakdown of visceral fat. He was saying if you're not obese, insulin resistant, you should be between 20 to 45. Not sure what that means. Does the AI block the receptors, and can this cause major issues? Thanks, doctor. Aaron Croft. Okay. So, boy, this is a big question. I get asked all the time about AIs because people go online these days, and you know what I tell people often is that what are you going to read online? You're going to read when everything's hunky-dory, normal, or going great, or you're going to read when somebody thinks a disaster has occurred. So you're definitely going to see information skewed towards something going wrong rather than, hey, this is great. What do they say? You know, people will tell 20 people about, you know, a bad thing, a bad experience, as opposed to maybe 2 people will mention a good thing or something like that.
That's right. I get it.
So without doing an ad hominem attack, he's not a doctor. Now, that said, I mean, there are guys out there that are providing valuable information like Nelson Virgil, who's not a doctor either. But he's well educated. I think he's a former chemist. And he does his research, and he will at least say things that aren't, well, he doesn't say things that aren't true, and doesn't say risky things, if I can say it that way. Okay, my problem with is that I don't know what research he's looking at, but from what I see, he's twisting the research, okay? When he says something, for example, and you know what, this isn't fair either, because this is secondhand. I've already gotten on a podcast a long time ago with Nelson.
Oh, really?
And addressed the issue, but I think very, very lightly, because you know some of it's opinion, and that I can respect. Excuse me, but when you go against what's in the studies, then I have an issue. When he says here that even a microdose can cause, for example, bone density loss. Really? I suppose it can. A lot of things have the possibility, if the stars are aligned, to do something, but in general, for example, with people on males on testosterone replacement therapy, bone density issues because of even a microdose, even a major dose of anastrozole is ridiculous. These guys are moving weights typically. Even if they're not moving weights, they're doing weight-bearing exercise. Because why? Because they have the energy, because they're on testosterone again. So bone density issues, I've never, and I'm an accountant first before I'm a doctor, right? So I'm presumably honest and conservative. in all my years and all my patients, I've never seen a male with a bone density issue on TRT and on an AI, or any sort of SERM for that matter either. That's just, that's spinning the truth. Again, if he's being truly quoted, okay, then that's just not correct. Testosterone itself, we now know, can help with bone density in and of itself. So to limit the estrogen, not going to, especially in a microdose, or like I said, even a macrodose, that's just spinning yarn here, okay? And we can go on and on, but one thing that's not mentioned is what happens when you don't block the estrogen? Well, what we've known for years is, and I'm sure you know plenty of people in the gym, you can have an issue with gynecomastia, breast tissue growth, you can have an issue with water retention, fat retention, moodiness and irascibility, which a lot of people attribute to roid rage.
Yeah.
Okay, but while some steroids like halotestin, trenbolone can activate a more aggressiveness in the personality, those are not the norm. For most that I see with testosterone replacement therapy in particular, but with other anabolics like nandrolone, oxandrolone, I don't see an increase in aggressiveness. Unless someone is naturally aggressive, then it will leverage their tendency to be aggressive.
Right.
But typically what I see, because of the sense of well-being and the confidence, I see less aggression. I use the joke, some guy wants to show off in front of his wife, for example, and starting a fight, and you're with your girl on your way to dinner, you go, dude, you're right, man, I'm an idiot, go ahead. Because you'll crush the guy, and why waste your time? And you feel like, hey, I don't need to prove anything, man, I feel great. Does that make sense?
Yeah.
So I don't see that. But anyway, back to the estrogen control. One of the things that's ignored in all of this is, how about prostate cancer? There's a lot of information out there, and a lot of it's correlative, a lot of it's epidemiological, in other words, a lot of it's animal studies, but we have a lot of evidence that points to, particularly one of the estradiol 17 beta, that causes, that activates the genes which we all carry as men for prostate cancer. And we've got studies showing that when you use estrogen alone, you are, I'm thinking about how they design the studies. Anyway, all these studies are, you can just type in prostate cancer, estrogen, and you can see a multitude of studies that will address this and get the particulars correct. But testosterone alone, let's just put it this way, we've shown in many studies not only doesn't cause cancer, but can be used cyclically to treat cancer. Okay, so most people think of treating cancer, treating cancer. The answer is to castrate the men either physically or chemically. Nowadays we do it chemically, but in other words, stop the androgen production, the testosterone production. It's important to differentiate those two, though, and overdose the body with estrogens. Okay. Well, we're rethinking that for a number of reasons, including a lot of these studies. Again, one of which is to use, and it was a small study, but there were more than one of them. I think this one I'm thinking about had an N of 16 people, but they had cancer, and it was treated with a cycle on, a cycle off, and the cycle on was a super physiologic dose in one study. Another study, it wasn't even a super physiologic dose. It's a joke that those of us who know about TRT would kind of laugh at, like that wasn't even a dose of treatment, right? So, not to get too far afield here, but one of the issues that needs to be addressed is prostate cancer. Brain fog versus prostate cancer.
I know. I'll
take brain fog over prostate cancer, okay? And stops the breakdown of visceral fat. Really? How many patients? Well, not patients. How many guys do you know? How many patients have I seen get on testosterone replacement therapy with an appropriate dose of an AI or some other form of estrogen control who lose a ton of fat?
Yeah.
Again, maybe he's being misquoted here, but I can't tell you how many times patients come to me misquoting, saying stuff that's not true, asking if they can get off the AI, or telling me they already did because they watched one of the. Okay, yeah, again, I don't mean to sound unprofessional, but let's be responsible here. And
So you've heard this before. This is not your first time.
Well, yeah, and I actually treat patients for a living, as do a lot of other doctors who follow the same protocols. Maybe not to the T. I might get my patients' estradiol sensitive down to 15 to 20 picograms per milliliter, assuming they don't have any other issues going on. And again, the main reason for that is twofold. One, you'll see the free testosterone rise. You'll see an SHBG drop when you get to that tipping point, somewhere around like 21 picograms per milliliter. This is what I've observed over time. And I'm not the only one who's observed it, but also because don't forget you need some estrogen. I totally agree for heart, brain, and joint health. But because of the potential for prostate cancer, I want to have the minimum amount, assuming you don't have other factors. And you read about, joint pain, kind of a flu-like joint pain when people, bury their estrogen or whatever they're calling it on the internet now. I forget what the word they're using, but that's the latest thing going around is everyone who gets on an AI buries their estrogen. No, they don't. Some people do, and some people, they don't affect at all. Typically, rarely actually, does someone have an effect like, oh, my joints ache, or I feel like my tendons are weaker when they bring their estrogen down too low. Some people, again, very rarely will say it takes away from their libido. But most people, if we get their estrogen down to below 15 to 20 picograms per milliliter, don't even complain. And again, this is not just my patient population, which is a pretty decent sized one, but I talk to other physicians in the field who say, yeah, same. Now, you might have a physician like Dr. Lipschultz, who arguably is the godfather of all this medicine, right? The urologist out of Baylor, and he'll at least keep it within normal limits. And I would argue that the majority of doctors would do that too. To let it climb just because you're afraid of an AI, that makes no sense to me. And again, patients have brought me some of the videos. It doesn't prove otherwise just because some other person who doesn't state facts or misinterprets the facts or whatever says the same thing.
Yeah.
The studies are there. Maybe what we can do, I don't know if we can do this, but we can present them on the channel somehow. We can gather plenty of studies, but again, it doesn't take much to just write prostate cancer, estrogen, and you can see all the studies for yourself. I mean, I can help interpret them because some of them are pretty complicated, but there's some really good ones out there that if you can read the research, if you want to, you can do anything. They're pretty demonstrative as to how important it is to limit the amount of estrogen, particularly when you are taking testosterone, because testosterone is the hormone from which we derive estrogen, right? It gets aromatized. There's also presentations about the ratio, how important it is. So you can't just blanketly say, oh no, don't control your estrogen at all. It doesn't make sense.
Yeah.
So let me see if I answered everything here. Did I? I don't know. Sorry, I know I get off on tangents, but I just want to make sure that, I don't mean to go off on an ad hominem attack, but the science needs to be there if you're going to be presenting it to people as such, and that's not what I've seen. It's very frustrating when you see a patient come in who just read something online and decided to stop their medication. I mean, have you ever seen me tell anyone, and no doctor would do this, say, you know what, stop what you're doing right now. Go talk to another doctor because here's some other things to keep in mind. From what I've seen, it's just, blanket, no, don't take it. And people will go, oh, well, okay, I better not do that.
It's like there's too much information out there now. It's too accessible.
Okay, but look who you're getting, and again, I don't mean to attack, but who are you getting the information on? Someone who sees patients every day, or someone who can go and has, in my opinion, gone to look at the studies and misinterpreted them.
Yeah.
So anyway, just want to make sure the HCG, along with the cypionate and AI, may be a good idea. Again, we've talked about reasons for adding HCG or not.
Right.
So I don't really have a comment there. But he says the question, AIs will block the conversion from testosterone and estrogen. The way you want to control the estrogens themselves, for example, to block the conversion from estriol or estradiol into what we would all consider, I think across the board, everyone would consider estrone as a so-called bad estrogen. You might want to include some DIM or eat a lot of cruciferous vegetables like broccoli, cauliflower, mustard green family stuff, because you get the DIM, which will convert to something called I3C or indole 3 carbinol, which will block that conversion. You can't just take I3C. you can take a DIM pill, diethylmethane pill, cost you 20 cents a day for a 200 milligram capsule if you don't like your veggies, and that will protect you from the so-called bad estrogens. And that's important too, because one of the things that Joe Franceschi and I, another practitioner with us here, have been doing is lately getting a estriol, estrone, and estradiol sensitive panel, because we've noticed that guys are still having symptoms sometimes from either over or under suppressing the estradiol sensitive, because we used to use estradiol sensitive as a surrogate marker for all the estrogens. Well, we're finding that it doesn't really pan out. We probably shouldn't be using it as a surrogate marker at least all the time, and maybe never. We're going to find more information and put it together, and maybe present it formally later. But we'll see. For example, today I saw an estradiol sensitive of 4.6 and an estrone that was 94, which is clearly outside the range. Our range goes to 65, and I'm not giving you measurements, just to keep it simple. But that's interesting, right? Because using estradiol sensitive as a surrogate, you say, oh, well, you're oversuppressing your estrogen. I have been saying that, but yet your estrogen is still high. So what do we do about that? And this all stemmed from a very interesting case I won't bore you with, but having all the symptoms despite bearing his E2, his estradiol sensitive, we found his estrone was off the chart. So we threw in some DIM, corrected the situation. So it just points to the fact that it's not always as simple as we like to hope it is.
Yeah.
And, science is just that. It's always changing. We do the best we can with the information we have at the time. But the AI obviously will help the conversion in general, but within the different estrogens, we want to control them a little differently. And the best way I know of, again, is with the DIM or the foods we mentioned. Other than that, I don't see any questions that I missed. Do you?
No, I think that was his concern mostly.
All right.
Good one.
Thanks.